What I'd like to do is talk about convulsive status epilepticus, and particularly the trial that we've recently run in this area. So status epilepticus is the most common neurological condition that we see as a true emergency in our emergency departments. 20 per 100,000 children, or if you look at those very young children, it's 50 per 100,000 each year. And it's not without mortality and morbidity. It's the second most common reason for children to be admitted into paediatric intensive care units. And it's associated with about 3% mortality. And if we look at the children who actually get status, half of them, pardon me, are neurologically normal beforehand. And if we look at all the international guidelines about how to treat status, they all show the same thing. Give a benzo, give another benzo, give phenytoin or phosphenotoin. If we go to the Cochrane review and then look at the evidence behind these recommendations, we find there's very good randomized controlled trial evidence for benzodiazepines. But there are no trials in that Cochrane review on second-line agents. And in fact, those recommendations are based on nothing more than expert opinion. And if we look at phenytoin, it's not that flash. It only works in 60% of cases. And this comes from the largest study ever undertaken in status. It was done by the PREDICT group, and it involved 312 children. And we know that phenytoin is a dirty drug. It has a considerable number of adverse events. It causes arrhythmia, it causes hypertension. If you get the dose wrong, if you get the rate wrong, children die. And children have died in this country and died in the UK because of errors around drug administration with phenytoin. Over the last decade, we've heard an awful lot about levetiracetam, and it's quite attractive as an alternative to phenytoin. It's a broad-spectrum anti-epileptic medication. We can give it very quickly, and it's safe compared to the adverse event profile with phenytoin. And if you read all the sort of observational, non-experimental evidence on levetiracetam, you come out with a figure of about 80% in terms of its efficacy. So it's in this background of no randomized controlled trial evidence for second-line agents, levetiracetam working at about 80%, phenytoin working at about 60%, that we undertook the convulsive status epilepticus pediatric trial, known as ConSEPT. And the aim of this study was to determine whether IV levetiracetam at 40 milligrams per kilogram, given to a maximum of 3 grams, or IV phenytoin at 20 milligrams per kilogram up to 1 gram is the better second-line agent for status. And it was an open-labelled, randomised controlled trial of children presenting to emergency departments post 2 doses of benzos. We included children between 3 months and 16 years of age, and we excluded children who had actually using those 2 medications, who had previously had a second-line agent, who were allergic to the medications or had a management plan which said, don't give one of the 2 medications. Anyone who was pregnant or had a head injury, because we wanted people to do something else about those, and children who had previously been enrolled in the study. The study occurred from February 2014 to November last year, and it occurred in 13 PREDICT sites across Australia and New Zealand. The primary outcome for the study was clinical cessation of seizure activity 5 minutes after the study medication was given. And we defined this as termination of seizure activity such that the treating physician felt that the participant was no longer having abnormal movements or nystagmus and that they didn't have abnormal tone. We then videoed that primary assessment to deal with the fact that it was an open study. The study had 80% power to find a 20% difference between the two treatment groups. The secondary outcomes that we looked at was what was going on at 2 hours, the time that it took to stop the seizure, whether the children needed to be intubated, whether they needed to go to the intensive care unit, the length of stay, the cost associated with it, whether there were any serious adverse events, or whether there were any follow-up issues in the 1 month after they left hospital. So this is how the participants flowed through the study in terms of the study protocol. After 2 doses of benzodiazepine, they were randomized to one of the 2 treatment arms. If they received levetiracetam, they got that for 5 minutes, and then they had their primary outcome assessment 5 minutes following that. If they were still fitting at that time, then clinicians could give phenytoin. Alternatively, on the other side, participants received 20 minutes of phenytoin, and then 5 minutes after that, they had their primary outcome assessment. If they were still fitting, following that, they then received levetiracetam. And at the end of all those things, then clinicians could do whatever they wanted to. And we encouraged people to basically do what the guidelines said and essentially intubate those patients. The study used retrospective consent, and so what we did when the children were stabilized, we went to the families and we said, can we use your child's data for the study? So what did we find? Over the 3 years in those 13 hospitals, 639 children presented in status. We missed 127 of them. We excluded 278, mainly because they were either on the study medications, they had a management plan which said, don't give phenytoin, or they had previously been randomized into the study. Only one family refused consent, and so we were left with 233 children, 114 in the phenytoin arm and 119 in the levetiracetam arm. These are their baseline characteristics, and they're very well balanced across the 2 groups. The mean age was 3.9 years. 50% of the patients were male. 50% of the patients were New Zealand or Australian European. There was developmental delay in 1/4 of the patients. 50% of the patients had previously had seizures, but only 20% of the patients were actually on an anticonvulsant medication. If we look at the seizure that had presented that patient into hospital, in 3/4 of cases, there was a febrile focus to that seizure. The median length of seizure was 1.2 hours prior to starting the ConSEPT medications. So these patients were truly in status. If we look at what drugs were used beforehand, over 90% of the patients received midazolam as their main benzodiazepine. Not surprisingly, a large amount of the patients actually required active airway management, and 1/3 of the patients in both groups required bag valve mask ventilation prior to us starting any of the study medications. So these patients were truly in that emergency critical phase of their illness. This slide shows the primary outcome for the study. So 5 minutes following the phenytoin infusion, 60% of those children had stopped fitting. And 5 minutes following the levetiracetam infusion, 50% of those patients had stopped fitting. There was no statistical difference between the two groups. And if we look at the modified intention to treat data set, so this is the children who are actively fitting at the time we gave the medication. There was no difference between the two groups. And if we look at the per protocol data set, so these excluded the children who had been intubated in the emergency department prior to giving the first study drug. Again, there was no difference between the two treatment groups. If we look at the important subgroups, so by age, by focal or generalized seizures, by febrile or afebrile seizures, by the type of benzodiazepine used, there was no difference between the two groups. There was no difference in the time that it took for the seizure to stop between the two groups. So a median of 0.4 hours and 0.3 hours. If we look at the 2-hour mark, in 78% of the Phenytoin children, their seizures were stopped with Phenytoin alone or Phenytoin followed by levetiracetam. If we look at the levetiracetam children, 72% of their seizures were stopped by levetiracetam alone or levetiracetam followed by Phenytoin. If we look at the children who were intubated in the study, there were 18% in the Phenytoin group, 26% in the levetiracetam. No difference between the groups. There was no difference in the rate of admission to the intensive care unit, length of stay in the intensive care unit, or length of stay in hospital. This shows the adverse events. Once again, the message is exactly the same, no difference between the two treatment groups. One child died during the follow-up of the study. That was on day 27, and that was a child in the Phenytoin group who had hemorrhagic encephalitis. And that death was not felt to be due to the study medications. There was no difference at follow-up in terms of the children, whether they were taking regular anticonvulsant medications, and that figure had really doubled from when they came into the study. There was no difference in the rate of seizures or in whether they had further episodes of status. There's some limitations to this work. So it was an open study. So we could have had some assessment bias in what those physicians thought was seizure activity at the time. However, we undertook video assessment in 2/3 of the cases, and that allows us to have independent assessment of that primary outcome. We didn't have EEG confirmation that they were actually fitting, nor that the fitting had actually stopped. And so there's a potential that we could have included some children with pseudo-seizures or with seizure mimics into the study, and that some of the children that we determined that the fitting had stopped, that actually they were having subtle seizure movements that we didn't pick up clinically. But none of our departments actually used an EEG, and the study reflects pragmatically what we all do every single day when we deal with these children. So in summary, we found no difference in seizure activity and stopping of seizures post the study medications of Phenytoin and levetiracetam, no difference at 2 hours of Phenytoin versus levetiracetam, and no difference at 2 hours of Phenytoin alone or Phenytoin followed by levetiracetam versus levetiracetam alone or levetiracetam followed by Phenytoin. There was no difference in adverse events. There was no difference in length of stay or ICU admission, and no difference in time to the seizure stopping. So I think I can very, very comfortably say that levetiracetam is not superior to phenytoin for second-line management of status. So what does all this mean for our everyday clinical practice? If we look at all those international guidelines, what they tell us to do is after phenytoin fails, we should then go on and intubate the patients. And we know that in refractory status, the time to the seizure stopping, particularly if the seizure's gone on for longer than an hour, is really important in terms of morbidity. But intubation is not without risk, and it's not without adverse events. And it certainly sucks up a lot of resources once it's occurred, because those patients essentially need to be transferred to the intensive care unit. And for smaller secondary sites, it means that those patients often need to be transported out of that hospital to a children's hospital. In ConSEPT, what we showed is that 40% of patients who were given phenytoin were still fitting after this. However, if levetiracetam was subsequently given, over 50% of those patients could actually be rescued and not need intubation. And I think this is the real take-home message from ConSEPT, that our treatment algorithm should now look something like this. Give a benzo, give another benzo, give phenytoin or levetiracetam, and if that doesn't work, give levetiracetam or phenytoin. And if neither of those drugs work, then move on to intubation. What this does is it gives us far better success rate prior to intubation, and it gives us that in a timely, all-important manner. Ultimately, which of those two drugs that we should give first is probably going to be decided by meta-analysis. And there are two other studies which are happening internationally, and their results are going to be coming out in the next year or so as well. There's the Eclipse study on the left from the UK, which is comparing phenytoin and levetiracetam, and there's the Eset study in the US, which is a platform design looking at levetiracetam, fosphenytoin, and valproate in both adults and children. But I think together, all three of those studies are going to help with the decision of which of those two medications that we should give first. This has been a huge amount of work, probably over at least 8 years, and it involves an incredibly amount of dedicated people in order to get this study, particularly in a very acute setting, over the line. And I've listed all the people there from the 13 hospitals that were involved in the study. And particularly, I think the other people that I'd like to thank is all the other people who work in those emergency departments who helped us, as well as the patients and their families who kindly consented to us allowing to use their data. And I'm more than happy to answer any questions, and I survived.
You had your understudy here anyway, so I was ready to do that. All right, anyone again who wants to ask a question, come on up to the microphone. As you say, big study, a lot of eagerly awaited results, and now thinking about changes to practice. Mel, comments or thoughts from Twitter?
Yeah, I'm struggling to keep up. Twitter got really busy towards the end of that session. So a lot of people were mirroring your feelings about phenytoin and being quite a dirty drug, and there was lots of comments on that early on. Katie Reeves had a question about what is the monetary cost of a dose of phenytoin versus a dose of levetiracetam?
So levetiracetam is probably about, depending on which economy you're in, somewhere between about $50 or $100. Phenytoin is cheap, so it's less than $1. But ultimately, if you're talking about avoiding intubation, that cost of that single dose just doesn't really even come into it. And as we have generics coming on the market for intravenous levetiracetam, that price is actually going to decrease dramatically. So I don't think that's going to be a big play overall.
And there were a few comparisons shared about the Eclipse study in the UK, and Damien Rolliner said he'd had a very positive experience using delayed consent as part of that study. Did you have a similar experience?
Well, I think that's one of the really nice things about the study. So the study that Franz presented used the same delayed consent as what we used in ConSEPT, and generally the families were incredibly supportive of the consent process as part of that. And I think that's probably a reflection of how they feel about us and the care that we deliver to their children, but also, pardon me, an understanding that we couldn't actually go and ask them beforehand.
Mm-hmm. Yeah.
This is an incredible work, an incredible amount of hard work, so congratulations. One thing that struck me though, it's not necessarily that there's no difference as much as it's null. And supposing you recruited, say, 200 patients in each arm, based on what you were getting there, is it possible that in fact, to everyone's horror, you would have found Phenytoin was slightly better? Because the confidence intervals with those numbers do suggest that, you know, given a large enough study, if we did it enough times, we'd find something between, you know, a 40%, you know, decreased rate of seizures in the Phenytoin group versus 7% more in the Keppra group.
Well, I think that's a really excellent comment. When we undertook the study to begin with, we looked at the literature and we got the 60% right for the Phenytoin, and that's what we had looked at our sample. But if you looked at the literature and you thought about levetiracetam, the figure that they were giving was 80%. But obviously there was a large amount of publication bias in that material, and that's a classic example of why we should undertake randomized controlled trials. But I think ultimately it's going to come with meta-analysis, where we combine the UK data, we can combine the US data. It's going to have a far larger data set, and we can see whether there's a true difference between the groups.
And another question from the floor. And so I might just get you to introduce yourself too. And you do.
David McDonald, Bob Macquarie. Does this mean that the numbers are locked in, that it's 40 milligrams per kilogram of levetiracetam and 20 milligrams per kilogram of diazepam?
If you ask me, the numbers are locked in, yeah. That there is a little bit of debate in terms of what those numbers should be. There is debate in terms of how fast the drug should do. We were actually very aggressive in what we picked. So we picked 40 milligrams per kilogram, and we used that over 5 minutes, which was the narrowest margin that we could find in the literature. And we did that up to 3 grams because, again, there was good safety data on that as well. In the UK, they were a little bit more conservative in what they picked, and they had a maximum of 2.5 grams as well. I think if children are already on levetiracetam, what you could probably do is actually give a half loading dose and give 20 milligrams per kilogram. And there's good reason for why you'd want to do that as well, because if they're on levetiracetam and it's stopping their seizures and they're having more, pouring a bit more levetiracetam in to decrease their seizure threshold or raise their seizure threshold seems to be a very sensible thing to do. And levetiracetam's been used up to 60 milligrams per kilogram with pretty good safety data around it.
Excellent. And Mel, any final questions or comments indeed for any of our?
Yeah, a bit of late interest in the role of phenobarbital, and does it still have a role in convulsive status epilepticus?
I think probably not. And I think partly to do with that is the evidence is pretty clear that what we should do is intubate these patients if things aren't going well. Now, you've given 2 medications, they haven't stopped the seizure, therefore there's probably not much benefit in giving a third medication in terms of sort of post-benzo medications. And if you think about phenobarbital, it's another medication that has cardiovascular problems associated with it, and it needs to be given over 20 minutes. So what I think we should all be doing is we should be giving one of levetiracetam or Phenytoin. We should be getting our kit ready in order to intubate the patients because we know that that all takes some time. If they're still fitting after the first one, we should give the second one. We should then really prepare ourselves for intubation, and then if they're still fitting, then we should intubate the patients. And so I think it's that preparation which then allows us to intubate early, and it's that lack of preparation which means that patients are given 4 or 5 drugs.
I'll always let Damien roll and have the last question.
It's not really a question, it's just a really big thanks for choosing to release the results at Don't Forget the Bubbles conference. It's only the second time it's been here. It's not a massive academic event.
Thanks, Damien.